It was an interesting case. A lady had a PE and she also had cholecystitis. I guess the acuity of both is actually unknown. So the surgeons weren't sure it was acute versus acute on chronic. But it really doesn't make a difference, as in you gotta deal with it, right? With the PE, well, yeah, I think that was also a question of when. So did it just come on? It hadn't been treated because we just discovered it, but it was found incidentally on a CT scan of her abdomen, which included a segment of her lung. So, did she have symptoms from the PE? It's hard to say. She did have metastatic cancer. That's why she got the CT scan because her oncologist was worried about her abdominal symptoms. But pleuritic chest pain with a PE versus with cholecystitis? I mean, who knows what's causing it? See, the thing is, many times the symptoms don't always correlate. I was getting a sign out about my patients in the hospital and they got a CT scan because she had pleuritic chest pain, right-sided chest wall pain. What does it mean? Can you correlate it? I think often we cannot. So the question is, did she have onset of symptoms correlating with when her P may have been? Was it a week ago, a month ago? Who knows? Because maybe her symptoms didn't correlate to the P and it was more an incidental finding. Either way, the question is, what do we do now? So obviously there's the medicine team and the surgery team. The surgery team decided that it's too dangerous with a fresh PE to do surgery, so they asked IR to do a cholecystostomy tube and sent her out with it. Is that the proper treatment? See, I always learned, though I'm not a surgeon, that cholecystostomy tubes are actually maybe more dangerous than just doing cholecystectomies. The idea of a laparoscopic cholecystectomy is that it's pretty safe. You rarely have any issues. I've seen one bowel leak in my life. Another time I suspected it, but it wasn't there. But it's usually not that bad. I mean, people say it's life-threatening, but not that bad. And then the other thing is, she's a young person, not yet 60. Should you just take care of it instead of sending her out with a tube in her belly for weeks on end? But what about the PE? And so I talked to a few people about the question of what should have been done. So what was done was she went out with a cholecystostomy tube, and the surgeon's going to see her back in a month and a half to plan for a cholecystectomy. And with the tube in, you're draining, so you should be fine. However, my question is, what was the best solution? And so I talked to my friend who's a surgeon. He does trauma, general surgery. And he's saying, here's the deal. We both think she should be fine with this PE, but what if something bad happened? They would blame it on the surgeon, saying, hey, shouldn't they have known there's a PE? You don't operate on people with PEs. Good question, right? I mean, I saw this case earlier when the lady's like, I'm fine, I'm fine. And the cardiologist's like, wow, she has severe aortic stenosis. She doesn't really have severe aortic stenosis. She has severe hypertrophic cardiomyopathy, which acts like aortic stenosis, the outflow tract obstruction. But he's like, wow, I don't know about this. I can't optimize her any further. I mean, she had a GI bleed. You can't really put on a beta blocker or thing because the pressures aren't. Yeah, this sounds bad, right? You could try to stabilize her. But the real reason is because GI doctor saw her elevated troponin. And he's like, I'm fine. I've had this done before. Can you just get it over with? And this cardiologist was really concerned. I said, you need to speak to an anesthesiologist. Maybe get a cardiac anesthetist. And I spoke to an anesthesiologist, and who didn't seem to be too concerned, and the lady made it out fine. I guess she was fine. She's had prior experience, and she's had this before. And she's came out fine. I guess it wasn't a big deal getting endoscopy. But if something had happened, they'd blame you for not talking to the surgeon, not talking to cardiologists, not talking to this or that person, to the experts, shall we say. When in reality, the experts don't really have much to add. That is, we don't really know much about it, so we have nothing to say to it. And I think that's complicated. So I talked to my friend who's an oncologist. She's not specialized in hematology, but then neither is really anybody else. There are people who have done hematology training, but there are people who have actually done hematology. So that's the difference, because a lot of oncologists go through hematology. Well, whether or not they're good in it is another thing. And whether or not they actually know benign heme is another question. Very few people know benign hematology because it's not where you make the money. There's tumors with hematology, like we say non-solid tumors. We don't call them liquid. But like leukemia, lymphoma, even though it's more solid, we call those non-solid tumors, hematologic malignancies. And so in those cases, you have hematologists and they make money. But just doing benign heme, like thrombocytopenia, coagulation, there's not that many people doing it, not that many people who know much about it. But anyway, she was saying, well, yeah, I mean, I don't know what to do in this case. And we talked about what data we have, how we don't know much about clots anyways. But she's like, yeah, I would think cholecystitis is dangerous. You take care of that first. I'll worry about this later. That's what I would say. And that's because we're medical doctors. We don't do surgeries. And I was pondering this over the span of a week when I talked to all these different people. I was thinking about this as lying on a bed. I was thinking about this as driving along, returning my rental car. It finally hit me. The reason we don't know what to do is because we don't actually know the other person's field. We're basically separated into the surgical world and the medical world nowadays. You may say there's overlap by people who do procedures. Lots of medical doctors, internal medicine trained people do procedures, and that's absolutely true and doing more and more. But then today, we're still not surgeons. We don't take out entire organs like your gallbladder. We don't know what it is like to cut someone literally open. There's a lot of stuff they talk about that we don't know. Like, we know there's post-operative ileus when you do bowel surgery. I know that, there's nothing to do to stimulate the gut again. You may try to wean off your narcotics, get them to ambulate more. But the question is, why? And my friend was saying with laparoscopic procedures nowadays, they feed them the same night. No big deal. With his cholecystectomies, his gallbladder resections, saying they're doing laparoscopic colon resections, small bowel resections, and they're feeding them the day after. They don't have ileus issues. Or if their ileus is there, it's very, very short compared to the duration of somebody who's had open surgery. And he says maybe it's the fact that you change the temperature because you expose them to much colder temperatures when you cut open the belly. Or maybe it's the fact that you touch it by your hand versus touch it with a little device. All these things I know nothing about, but surgeons know, and surgeons worry. And surgeons do a lot based on tradition and history, whereas I think there's more medical doctors who don't. And the thing is, we're all afraid of things we don't know, and we actually over-exaggerate the danger of things we don't know. And I think that's why the surgeon is so afraid of the PE. And that's why I'm so afraid of the gallbladder inflammation. My friend said, oh, with the gallbladder, no big deal. They rupture. They're not going to kill you. Really? Oh, I thought, you were supposed to take care of it. But to him, no big deal, right? Appendectomies? Yeah, appendicitis. I thought it was a big deal. Nowadays, they're saying, maybe you could treat some of these medically. Really? I don't know. But what I could tell you is many cases that they're thinking we need to get on this right away. We're like, what's the hurry? Heart attack? Yeah, give her an aspirin, deal with it tomorrow. Beta blocker if pressures are good, maybe. I'm in no hurry. It's just a heart attack. What's the big deal? PE, what's the big deal? So many people have it. They do fine. Have such good medications nowadays. But when you don't know, wow, is it scary?